Welcome to the deep dive. Think about this for a second. The idea of using pressure to help the body heal isn't some trendy new thing.
Not at all.
We're talking about roots going way back to the 17th century, believe it or not, when they were already kind of playing with compressed air.
Right, long before we really understood the oxygen part.
And then you had this incredible character, Dr. Cunningham, who built a 5-story hyperbaric chamber, this like massive structure.
Yeah, that thing was huge.
Hoping to cure everything under the sun, syphilis, cancer, diabetes, based on this idea about anaerobic infection.
It sounds a bit wild now, doesn't it? Like science fiction.
Totally. But it just shows how long we've been fascinated by the power of pressure in medicine.
It's truly fascinating how that early sort of experimental phase, while maybe not always hitting the mark scientifically,
Right.
it really did pave the way for what we now recognize as a vital part of modern medicine. Hyperbaric Oxygen Therapy, or HBOT.
Yeah.
It's a testament to, I guess, human curiosity and that slow, steady march of scientific understanding.
Absolutely. And that's exactly what we're plunging into today. We're taking a close look at hyperbaric oxygen therapy and its established crucial role in how doctors are treating a really diverse set of medical conditions right now.
And our guide for this journey.
Our guide for this deep dive. We're navigating the comprehensive landscape of Jain's textbook of hyperbaric medicine, the 6th edition.
Cornerstone text in the field.
Exactly. So you can consider this not just an exploration of why HBOT matters today, but also, a practical look at what this definitive book offers for anyone wanting to truly get a handle on the field.
That's incredibly thorough. If we step back and look at the bigger picture, what we aim to show you is the journey HBOT has taken. From those early, maybe somewhat speculative uses to becoming a truly integrated and respected tool in healthcare.
Right.
We'll break down the core science, look at its many applications. From speeding up wound healing to its role in neurological recovery, tackling serious infections.
A really wide range.
Definitely. And of course, we have to discuss the essential safety considerations and, where this important area of medicine might be heading next.
So for you, the learner, our mission is simple. To give you a clear picture of how HBOT isn't some, fringe treatment anymore.
Far from it.
It's a therapy firmly rooted in science and clinical evidence, making a real, tangible difference in patient outcomes. Okay, let's get into the foundational stuff, what's actually happening with the pressure and the oxygen.
Right. At its heart, HBOT operates on a very direct principle.
Okay.
By placing someone in a chamber where the pressure is higher than normal atmospheric pressure.
Higher than just breathing air at sea level.
Exactly. We can significantly increase the amount of oxygen that dissolves directly into their bloodstream, the plasma, the liquid part of their blood, not just what's carried by red blood cells.
And the numbers really drive this home, don't they? Jain's textbook in Table 2.4 lays it out so clearly.
It does.
Normally at 1 ATA, that's our standard atmospheric pressure breathing regular air, you've got about, 0.32% dissolved oxygen in arterial blood?
Tiny amount, relatively speaking.
But if you increase that pressure to 2 ATA, just double it, and have them breathe 100% oxygen, that dissolved oxygen level skyrockets to 4.44%.
Huge jump.
And then bump it up to 3 ATA of 100% oxygen, and you're looking at 6.80%. That's an enormous increase in oxygen just floating around, ready to be used.
It is. And interestingly, as the book points out, oxygen administration usually doesn't go beyond 3 ATA for most therapies. There are reasons for that, related to safety.
Which we'll get into later, I'm sure.
Definitely. But what's key to grasp here is that this surge of dissolved oxygen effectively saturates the tissues. It gets oxygen to places that might be starved, hypoxic.
Right.
Figure 2.5 in the textbook gives a nice visual of how the body's oxygen uptake curve changes dramatically under these hyperbaric conditions.
So it forces oxygen into areas that desperately need it.
Precisely. And as Chapter 5 delves into, this enhanced oxygen delivery can trigger significant physiological improvements. It can help counteract tissue acidosis, for instance.
Acidosis, that's the acid buildup in oxygen-starved tissues.
Exactly. It hinders healing and normal function. So think of HBOT as flushing out that toxic environment with life-giving oxygen.
Okay, so we're not just delivering more oxygen, we're enabling it to penetrate and kind of revitalize areas that are struggling.
That's a great way to put it.
Now, it's worth remembering, like you said, those early hyperbaric chambers weren't using pure oxygen.
No, they weren't.
That came later. And here's where it gets really interesting. oxygen itself wasn't truly identified until 1775 by Joseph Priestley.
That's right, as Jain actually details in his earlier work, specifically on the history of oxygen, which is also fascinating reading, by the way.
Oh, okay.
Well, the concept of using pressurized air for medical benefits dates back to the mid-17th century. The intentional use of pure oxygen in hyperbaric chambers developed much later.
And Jane's textbook of hyperbaric medicine, the main one we're looking at today, Table 1.3, highlights some of these crucial milestones in the evolution of HBOT, doesn't it?
It does. It maps out that progression really well.
And some of those initial uses of compressed air, while ambitious, were based on theories we now know weren't quite right, weren't they?
Oh, definitely.
Like Cunningham's idea that anaerobic infections were the root of so many different diseases. I mean, a 5-story chamber in Cleveland, 64 feet across,
Well,
with hotel rooms inside.
can you imagine the
Yeah.
scale? It was apparently the only one like it operating at the time. A huge investment based on, well, a flawed hypothesis.
Yeah.
It certainly speaks to the enthusiasm, maybe a degree of oversimplification in early medical thinking. But if we fast forward, that same table 1.3 marks significant turning points when researchers began to pinpoint the real potential of HBOT with oxygen.
Right, the modern approach.
Exactly. For instance, the work of Saltzman and his team in the U.S. back in 1966 showed positive effects in stroke patients. That was a big step. Then you see research popping up in the 70s in Czechoslovakia on multiple sclerosis, in Germany on sudden deafness, even early work showing reduced mortality in heart attacks. These were crucial steps.
Validating specific uses.
Precisely. Recognizing HBOT's specific therapeutic value, not just a general pressure cure-all.
And this wasn't just happening in one corner of the world, right? The book mentions significant growth elsewhere, too.
Absolutely. The 1970s saw a big increase in hyperbaric facilities in Japan and the USSR. Then China saw development in the 1980s. It was becoming a global field.
And a key moment for the field in the U.S., mentioned in the book, was the formation of the American College of Hyperbaric Medicine in 1983.
Yes, that was important. It signaled a growing professional recognition, a move towards standardizing the practice.
Okay, so with that background on the science and the history, let's move on to the actual equipment that makes this therapy possible, the hyperbaric chambers themselves.
Right. Chapter 7 of Jane's textbook provides a really comprehensive overview here.
Yeah.
It's great for anyone interested in the practical side, the hardware.
Okay, so in terms of the hardware, these are basically specialized chambers built to safely withstand high pressure,
Very high pressure, yeah.
allowing for that administration of oxygen at concentrations way higher than normal air.
Much higher.
The book details 2 main types. Hard shell chambers, usually steel or aluminum, right? And then softer, more portable monoplace options.
Correct. And regardless of the type, they all have viewports, those clear acrylic windows so you can see the patient,
Crucial.
and sophisticated control panels. You need to monitor and adjust pressure, the gas mix, the patient's status, plus have good two-way communication.
Makes sense.
And it's really important to understand the difference between monoplace and multiplace chambers. Table 7.1 and the illustrations in Chapter 7 show this clearly.
Okay, break that down for us.
Well, monoplace chambers are for just one patient at a time. They're typically filled entirely with 100% oxygen, pressurizing the whole chamber with it.
Got it. Single occupancy, oxygen filled.
Right. Multiplace chambers are larger. They can hold multiple patients, sometimes medical staff too. These are pressurized with regular air, and the patients breathe 100% oxygen through masks or hoods.
Ah, okay. So the air around them is normal air under pressure, but they breathe pure oxygen.
Exactly.
There are definitely trade-offs with each, right? The book touches on this.
For sure.
Monoplace chambers seem simpler, in some ways easier for direct observation, maybe don't need special decompression for staff,
Generally, yeah.
can be more economical maybe, space and cost-wise, fewer operators needed.
Those are potential advantages. But the big downside, or a major consideration, is the fire risk. Filling the whole space with pure oxygen.
Yeah, that sounds inherently risky.
It requires extremely strict safety protocols, as Chapter 7 emphasizes. No electrical devices inside, non-synthetic clothing only, no oil-based cosmetics, things like that. It's critical.
And I imagine direct physical access to the patient during treatment is limited in a monoplace.
It is. And the capabilities for advanced respiratory support, like mechanical ventilation, might be more basic compared to multiplace units.
Okay, so multiplace chambers sound like they offer a much broader scope, especially for sicker patients.
They do indeed. Figure 7.5 gives a good sense of their capacity. Because they're pressurized with air, trained medical staff can actually go inside with the patients.
That's a huge advantage.
It is, especially for critically ill patients. As Lynn's review, which is cited in Chapter 7, highlights, these multiplace chambers essentially extend the capabilities of the ICU.
Wow. Like an ICU under pressure.
Pretty much. You can perform standard critical care, mechanical ventilation, continuous monitoring, even resuscitation efforts, all while under pressure.
That's a significant capability, but I guess that comes with more complexity in operation.
Oh, absolutely. It requires highly trained teams. And the textbook does mention the historical challenges and ongoing advancements regarding using electrical equipment like defibrillators safely under pressure.
Right, safety is paramount.
Always. But the ability to provide that comprehensive medical management makes multiplace chambers invaluable for a wide range of complex conditions.
Okay, so that covers the technology.
Now let's transition to where HBOT really shows its clinical value, its diverse applications across so many medical specialties. This is where we see its integration into mainstream medicine, and Jain's textbook dedicates, significant sections to these areas, a huge part of the book.
Absolutely. And Chapter 16 delves deeply into HBOT in wound healing, plastic surgery, and dermatology. It's amazing how just increasing oxygen levels in damaged tissues can create such a better environment for repair.
Especially in those really tough cases, patients with compromised circulation, chronic non-healing wounds.
Yeah.
And the biology, as the textbook explains, is key. Our cells' powerhouses, the mitochondria, need a certain baseline oxygen level to work properly, usually between 0.5 and 3 mmHg for oxidative phosphorylation, the energy-making process.
Okay.
When tissue oxygen drops below about 30 mmHg, the activity of key enzymes involved just tanks.
It shuts down, basically.
Pretty much. HBOT effectively cranks those oxygen tensions way up. Table 16.3 details this HEF. A poorly healing wound might only have 520 mmHg oxygen normally, but at 2 ATA of 100% oxygen, that can jump to 600-800 mmHg.
Wow, that's an incredible boost. It just makes intuitive sense that flooding the area with oxygen would help.
It does, and the chapter also discusses using topical HBOT for things like leg ulcers and how it boosts VEGF expression.
VEGF, vascular endothelial growth factor, for new blood vessels.
Exactly. Crucial for healing. There's also evidence for better survival of skin grafts and flaps, both stored under HBOT and in animal models. It's not just chronic wounds, it has roles in severe conditions like purpura fulminans too.
So Chapter 16 really highlights HBOT as a tool for optimizing tissue health in tricky situations, a key resource for surgeons and dermatologists in the textbook.
Definitely. Now moving to Chapter 17, we find HBOT playing a vital role in managing radionecrosis.
Ah, those persistent non-healing wounds that can happen late after radiation therapy.
Exactly. The principle is similar. Improve oxygenation in tissues damaged by radiation, which often suffer from poor blood supply and chronic inflammation.
And it's interesting, the book points out HBOT isn't typically used right after radiation.
Correct. There's concern it could worsen acute effects, but in the longer term, it can be very beneficial. It's even shown promise in helping implants integrate into previously irradiated bone, at least in animal studies.
What about specific radiation injuries?
Well, the outcomes for radiation-induced optic neuropathy, ION, seem a bit mixed, according to the chapter. But HBOT has shown significant promise for radiation proctitis inflammation of the rectum, often reducing or even resolving symptoms completely.
That's huge for quality of life.
It is. And it's also proven effective for hemorrhagic cystitis and proctitis, helping control bleeding. It's a key intervention for mitigating some of those debilitating long-term radiation side effects.
And the evidence seems pretty solid here.
Yeah, the data from that large registry study by Niezgoda et al. In 2016, cited in Chapter 17, is quite compelling. It showed significant improvement in a high percentage of patients across various radiation injuries.
Okay.
And the systematic review by Bennett and colleagues, also cited, further supports its efficacy. This solid evidence base really reinforces HBOT's place as a recognized treatment for these tough complications. Jain's chapter leads this out very well.
Okay, now let's shift focus to the body's defense system's infections. Chapter 14 details how HBOT can be a powerful ally here. This seems like another critical area covered in the book.
It absolutely is. As Chapter 14 explains, HBOT works through several mechanisms against infections. It can enhance the function of our white blood cells, the fighters.
Makes them work better.
Yeah, it boosts phagocytosis. That's the process where immune cells engulf and destroy bacteria. It generally strengthens the immune response overall.
Interesting.
And interestingly, HBOT can also directly produce reactive oxygen species, free radicals, which are actually toxic to many microorganisms.
So it fights them directly, too.
It can. Plus, it can work synergistically with certain antibiotics, like sulfonamides, making them more effective. It can even help in cases of drug-resistant infections.
Wow.
And a key point the chapter makes is that many antibiotics actually need adequate tissue oxygen to work properly in the first place, something HBOT directly provides.
That makes sense. So where is it most crucial?
Well, Chapter 14 really underscores its critical role in severe, life-threatening infections like necrotizing soft tissue infections, those flesh-eating bacteria cases.
Right.
It's not a standalone cure, obviously, but a vital part of the plan, alongside antibiotics and aggressive surgical debridement.
The three pillars: surgery, antibiotics, HBOT.
Exactly. The chapter also notes that gas gangrene antitoxins are largely considered obsolete now, with early aggressive HBOT being a cornerstone of managing that specific dangerous infection.
Okay.
And even in more chronic anaerobic infections like actinomycosis, HBOT is recommended as a valuable addition to surgery and antibiotics. Chapter 14 really builds a strong case for HBOT's essential role in managing complex and severe infections.
Another really critical application covered thoroughly in Chapter 13 is carbon monoxide poisoning
Right.
and other tissue poisons.
Absolutely critical, yes. Carbon monoxide is so dangerous because it binds to hemoglobin much more strongly than oxygen does.
Steals oxygen seat on the bus, basically.
That's a good analogy. It leads to severe oxygen deprivation in the brain and other organs' cerebral hypoxia. And the chapter notes CO can also directly damage the blood-brain barrier, making things even worse.
And diagnosing it can be tricky. Chapter 13 mentions that.
It can. Symptoms aren't always specific, and they don't always match up perfectly with the measured carboxyhemoglobin, the COHB levels, in the blood.
But Jane's textbook is clear on the treatment for significant CO poisoning, like loss of consciousness, coma, neurological issues.
Unambiguous. HBOT is the treatment of choice, the gold standard. The typical protocol, detailed in the chapter, involves an initial period at higher pressure, usually 3 ATA, then a longer period at 2 ATA, until those COHB levels drop below a safe threshold.
So this chapter is essential reading for understanding HBOT's life-saving role in these emergencies.
Absolutely. The chapter also wisely points out potential complications in comatose patients, like eardrum rupture at higher pressures.
Need careful management.
Definitely. And it mentions a statistically significant finding of increased seizure risk at higher HBO pressures in co-poisoned patients who already have brain injury. So monitoring is key.
And a crucial takeaway from Chapter 13 is that the initial COHB level alone doesn't always predict how severe it is long-term.
Correct. Which further emphasizes why getting HBOT is so important to mitigate that potential neurological damage, regardless of the initial number.
And Chapter 20 also briefly mentions HBOT for cyanide poisoning.
It does, yes. Another metabolic poison where HBOT can be life-saving.
Okay. Now let's turn to something often linked with diving decompression sickness. Chapter 11 covers this.
Expertly covered, yes. Chapter 11 provides a really comprehensive look at the physiology and treatment.
So DCS, or the bends, that's about gas bubbles forming in the body.
Exactly. When dissolved inert gases, mainly nitrogen, come out of solution too quickly after a pressure decrease, they form bubbles.
And these bubbles can cause trouble anywhere.
Pretty much any organ system. Chapter 11 describes the different manifestations, lung issues called the chokes, neurological problems from mild to severe, even that characteristic skin rash, cutis marmorata. It's a vital resource for dieting medicine folks.
And HBOT is the go-to treatment. How does it work here?
As the chapter explained, it works in several ways. The increased pressure physically shrinks the bubbles.
Compresses them.
Right. And the high oxygen concentration improves oxygenation in the affected tissues and, crucially, helps wash out that excess nitrogen faster.
Accelerates getting rid of the problem gas.
Precisely. Chapter 11 details the different types of DCS and the specific oxygen treatment tables used. For severe cases needing deeper recompression, it discusses using helium-oxygen mixes, HELIOX, following established protocols like the U.S. Navy's.
So HBOT is directly tackling the cause and effects of DCS, another clear mainstream application covered in the book.
Absolutely. It's fascinating how that elevated oxygen pressure helps restore normal tissue function, especially in the nervous system, as the research cited in Chapter 11 shows.
Okay, now shifting to a really vast and complex area, Neurological disorders. Jane's textbook dedicates several chapters to this, right? 18 to 23.
Yes, it's a significant focus of the book and a major area of modern HBOT research. It's rapidly evolving.
Very exciting. What about stroke? Chapter 19 covers that.
It does. It references early studies showing promise and later animal studies demonstrating neuroprotective effects.
So is it standard treatment now?
Not universally first line for acute stroke, no.
Yeah.
But some clinical studies, mentioned in the chapter, have reported improvements in neurological function, even reduced spasticity, especially when combined with physical therapy.
The idea of neuroplasticity comes into play here, the brain rewiring itself.
Exactly. That's thought to be a key part of how HBOT might help stroke recovery. Interestingly, Chapter 20 includes perspectives from experts like Dr. Harch, who argue that HBOT is perhaps underutilized for neurological conditions in the U.S.
So these chapters give a good overview of the current state and ongoing research for stroke.
You do. Then Chapter 21 looks at traumatic brain injury, TBI.
Okay.
It highlights early clinical observations suggesting benefits and discusses how our understanding of the mechanism has evolved. It's not just about reducing swelling anymore, but maybe improving brain cell metabolism.
More fundamental effects.
Potentially. The chapter stresses how critical it is to monitor intracranial pressure and brain metabolism in TBI patients getting HBOT. And it calls for more large-scale trials to really nail down its role and the best protocols.
Makes sense. It's complex. What about spinal cord injury, SCI? That's in Chapter 18.
Yes. Chapter 18 outlines the rationale, potentially helping reversible neuronal damage early on, alleviating ischemia, lack of blood flow, reducing swelling, correcting biochemical issues at the injury site.
Seems logical.
The chapter draws on clinical experience suggesting HBOT might be beneficial in severe traumatic spinal cord injuries, especially if started early. Needs more research, but it presents a compelling case for considering it.
Okay. Cerebral palsy is another area, Chapter 23. That's seen some debate, hasn't it?
It has. Chapter 23 reviews early findings from Brazil that reported improvements, like reduced spasticity. But it also critically looks at later placebo-controlled studies with more mixed results.
Why the difference?
Potentially variations in patient selection, treatment protocols. It's complex. However, more recent studies, like one by Mukherjee discussed in the chapter, have again suggested significant improvements in hyperbaric groups compared to rehab alone.
Interesting. And animal studies, too.
Yes, animal studies referenced in the chapter show promising cognitive and vascular benefits in relevant brain injury models. So Chapter 23 gives a balanced look at the evidence for CP.
What about multiple sclerosis, MS Chapter 22?
Chapter 22 recounts early use, noting some patients seem stable with long-term treatment. Table 22.5 shows data on that. But subsequent placebo-controlled studies, as the chapter discusses, had mixed outcomes. Some showed no significant benefit over sham treatments. Figure 22.4 illustrates some findings relating treatment numbers to disability scores.
So still an area of investigation for MS.
Very much so. Chapter 22 gives a comprehensive overview of that research landscape.
And Chapter 20 also covers global cerebral ischemia and coma, like after cardiac arrest.
Yes, widespread oxygen deprivation to the brain. Table 20.2 suggests potential roles for HBO in acute severe TBI and prolonged ischemia and anoxia. The chapter reviews studies by Holbach, Artru, Roxwold, and others exploring HBOT's potential in coma patients.
So valuable insights there too. And Chapter 18 briefly mentions optic nerve ischemia.
Just touches on it as another potential cranial nerve application. It's clear from all these chapters in Jane's book that the neurological applications are complex, evolving, and a major focus of hyperbaric medicine.
Definitely a key section of the textbook.
Sure.
Okay, let's shift gears beyond the brain. What about cardiovascular diseases, Chapter 25?
Right. Chapter 25 explores this. It's not presented as a primary fix for all heart conditions, but it discusses potential benefits in managing myocardial ischemia, especially in really severe cases with hypoxia, low blood pressure, acidosis.
So an adjunctive role in specific situations.
Exactly. And a really interesting area, highlighted in chapters 25 and 40, is hyperbaric oxygen preconditioning before cardiac surgery, like bypass surgery, CABG.
Preconditioning, treating before the surgery.
Yes. Studies discussed in these chapters suggest giving HBOT before surgery might reduce neurological issues afterwards, control inflammation, improve heart function, lower certain cardiac biomarkers.
Wow, proactive use.
And there's even research mentioned in Chapter 40 looking at HBOT to prevent restenosis re-narrowing after angioplasty. So potential to really enhance outcomes in cardiac procedures.
Fascinating. What about other areas? Hematology, gastroenterology, chapters 26, 27?
Briefly, yes. Chapter 26 discusses how HBOT might improve red blood cell deformability, how flexible they are, which is important for microcirculation.
Getting blood into tiny vessels.
Right. And Chapter 27 explores the rationale for HBOT and gastric ulcers, linking it to improving microcirculation and tackling hypoxia in the stomach lining. It also discusses promising research on HBOT for adhesive intestinal obstruction and inflammatory bowel diseases like Crohn's and ulcerative colitis, citing some positive studies and experimental evidence. Some broad potential interactions.
Even lungs, chapter 29 mentions pulmonary disorders.
It does. Describes hemodynamic effects
Yeah.
and mentions historical use in things like dust-induced bronchitis, but it also includes an important caution. Avoid it in patients with high CO2 levels unless they're properly ventilated.
Good safety point. And trauma, orthopedics, chapter 30.
Chapter 30 highlights HBOT's benefits in acute peripheral ischemia, things like compartment syndrome, severe crush injuries where it combats tissue hypoxia.
Makes sense.
It also touches on its potential role in supporting recovery from head injuries, reducing edema, and acute spinal cord injuries, so a valuable adjunct in managing severe trauma.
What about ENT, ear, nose, throat, chapter 31?
Otolaryngology, yes. Chapter 31 recognizes HBOT as valuable for sudden hearing loss and acute acoustic trauma, especially if started quickly.
Timing is key there.
Seems so. It also notes effectiveness for tinnitus linked to inner ear issues, though maybe less so for isolated tinnitus. And it highlights HBOT as effective for malignant otitis externa, a severe ear infection.
Okay. And it's even used in newborns, chapter 34.
Yes, growing acceptance there, as Chapter 34 discusses, citing historical reports and recent analyses. In HIE hypoxic ischemic encephalopathy, oxygen deprivation at birth, early HBOT might help mitigate brain damage.
Wow. Requires specialized care, I imagine.
Absolutely. The chapter stresses needing NICU-level care inside the chamber for these fragile patients.
And geriatrics, chapter 35. Any specific applications for older adults?
Chapter 35 outlines several potential uses. Cerebrovascular insufficiency, aiding stroke rehab, stroke prevention, cognitive disorders, peripheral vascular disease, chronic heart ischemia. It even touches on HBOT alongside mental training and exercise for healthy aging.
Interesting concept. What about organ transplants, chapter 39?
Chapter 39 explores how HBOT can help reduce ischemia-reperfusion injury, that damage that happens when blood flow returns to oxygen-starved tissue.
A big problem in transplants.
It is. The chapter discusses how HBOT can improve survival and function of transplanted hearts, thyroids, bowels, skin, possibly by reducing harmful inflammation signals.
Okay. And we touched on preconditioning before, but chapters 40, 42, 45, 47 seem to push into future research.
They do. They highlight ongoing research into cutting-edge areas. HBOT in resuscitation, using it with stem cells, personalized medicine, using imaging to tailor cancer therapy based on tumor oxygen. Chapter 47 specifically notes cancer and neurological disorders as key areas for the future.
So Jane's textbook really covers the established uses and points towards the future directions.
Absolutely. It's incredibly comprehensive.
It's abundantly clear that HBOT is being applied across an impressive and expanding range of specialties, all backed by research detailed in Jane's book. But, like any treatment, we need to talk safety.
Paramount, always. Chapter 6 provides a thorough overview of the risks, mainly focusing on oxygen toxicity.
Right, too much of a good thing.
Potentially. Can affect the lungs or the central nervous system. The risk depends on the pressure and how long the exposure is. Chapter 6 details the mechanisms and potential protective measures. Essential reading for safe practice.
And contraindications. Reasons not to use HBOT. Chapter 8 covers this.
Yes. Chapter 8 is clear. Untreated pneumothorax, collapsed lung, is the only absolute contraindication. Never use it then.
Okay.
But there are relative contraindications, like upper respiratory infections, which increase the risk of barotrauma, pressure injury, especially to the ears. Needs careful consideration. Chapter 8 gives that crucial guidance.
What about other potential risks? Genetics. Fire.
Well, Chapter 8 mentions that while some lab studies hinted at potential genetic effects, they're generally seen as transient and not clinically significant in standard treatments. Fire safety, though, is huge. We touched on it, but Chapter 7 and 48 really emphasize the strict adherence needed to safety regulations.
Yeah.
The historical accounts of accidents are a stark reminder. These chapters are vital for running a safe facility.
And finally, Chapter 48 brings up some important ethical points.
It does. Things like off-label use, using HBOT for conditions it's not formally approved for yet, and the evidence needed there.
Right.
Also, the difference between evidence-based HBOT and some mild hyperbaric treatments you might see marketed. The role of the placebo effect, and the constant need for rigorous clinical trials.
Keeping it scientific.
Exactly. The chapter also mentions variability in standards and regulations globally, using Latin America as an example from Chapter 51, which raises questions about access to quality care. It really encourages a thoughtful, evidence-based approach.
Okay. This brings us towards the end of our deep dive into hyperbaric oxygen therapy, using Jain's excellent textbook, 6th edition, as our guide.
It really is an invaluable resource for understanding the science and the clinical practice.
So, to kind of wrap it all up, what are the key takeaways here?
Well, I think the main thing is that HBOT is scientifically solid. It's not fringe anymore.
Right, it's moved into the mainstream.
Definitely. As Jane's textbook meticulously documents, it has a wide array of established uses, backed by a lot of research, and that research base keeps growing.
It's not a magic bullet, though.
No, not a panacea. It's a specific tool for specific conditions, working through physiological mechanisms we increasingly understand, and for anyone wanting that deep, authoritative understanding.
Jain's textbook is the place to go.
It really is the essential, comprehensive guide. We've only scratched the surface of the detail in its chapters. It underscores the ongoing research and how our understanding keeps evolving, crucial for clinicians and researchers.
Which leads us to a final thought for you, the learner. Considering this breadth of applications, the established science, and all the ongoing research highlighted in Jain's textbook, what other medical conditions might we find could benefit from this unique approach of delivering oxygen under pressure?
It's a fascinating question, isn't it? Where else could manipulating oxygen delivery make a critical difference as the field continues to evolve? Something to ponder.